Good morning, everybody. Thank you for deciding to join us and have breakfast with us and learn a little bit more about obesity and liver connection. Welcome to Obesity Dialogues Live, Beyond the Scales, the Obesity-Liver Connection. You see a QR code there for pre-activity to record some things, so please do so, and we'll show those a little bit more later. I'm Bob Kushner. I'm Professor Emeritus at Northwestern Medicine in Chicago, Illinois, and I'm pleased to be here along with the panel, Dr. Dhanani and Dr. Green. I'll have both of you introduce yourselves, if you will. Dr. Dhanani first.
Hi, good morning, everyone. I'm Amreen Dhanani. I'm a hepatologist at Duke. I'm really excited to be here, and thank you for joining us this morning.
And I'm Jennifer Green. I'm an endocrinologist, also at Duke. Good morning, everyone.
These are the objectives this morning, is to look at the pathophysiologic processes leading to development of obesity and associated comorbidities, including MASLD and MASH, implement evidence-based best practices, and evaluate new treatment approaches. And here's the agenda as well. If you haven't done so already, please complete the pre-assessment of this activity by scanning the QR code. We have a lot of audience response polling, so please be engaged. The format this morning is really set up for not a lecture style at all, as you can see, but really engagement and discussion. So please download that on so you can become an active participant. And there's also a pre-assessment that you can do. At the conclusion of the symposium, you'll be shown a QR code, which will take you to the post-assessment, as well as our symposium evaluation. After scanning the QR code, click Claim Your CME here on the landing page. Upon completion, you'll be prompted to download your certificates for CE. Also available there will be a download of all the slides. So that's important because we're going to be going through a lot of really cool data, important data, that you could then look at a little bit later as well. There's also cards at your table. Go ahead and write any questions. I'm not sure we're going to have time at the end. If we do, we'll get to them. If not, we will get back to those questions a little bit later. The activity is provided by MLI, a collaboration with the World Congress Insulin Resistance and MEF. And it's also supported by Boehringer Ingelheim Pharmaceuticals, and there's that QR code again. Accreditation is here. I'm going to kind of go through these pretty quickly. Disclosures are also available for you to look at. So we've divided this after I put in my other glasses so I could really look better at the slides now. We divided this up into three different segments. The first is pathophysiology of obesity, understanding mechanisms that modulate body weight and lead to obesity-associated comorbidities. You're going to see different slide types. One of them is polling time. You're going to see this repeatedly, so it's meant for you to prompt you to please use the polling, and this is what you're going to need to go to, which is menti.com. And you need to put this code in if you could, please, because we have a bunch of polling questions that helps us understand what you're thinking and helps guide our discussion. So that's what I have on here. And here's the first polling question. How far did you travel to get to this meeting? Less than 25 miles, 25 to 100 miles, 100 to 500 miles, or greater than 500 miles? So that will change a bit as you guys start doing that. And this obviously is a warm-up, just to make sure everyone's using it and has time to go ahead and get on the polling.
I don't see any hyperlocals.
Yeah.
Oh.
Yeah, interesting. 8%, less than 25 miles. Most of it, people flew in.
Yeah.
Okay. Thank you. Next one. How confident are you in your understanding of the shared pathophysiologic mechanism? This one's helpful for us to get an idea of what you guys are thinking before we actually launch this program. Looks like somewhat confident is more than half of you. Okay, That's good. That means we have a lot of opportunity to learn a lot of new information that you can then bring back to your patient care or apply in your clinical trials. Okay, so let's go forward. Okay, and this I believe we just did, right?
Yep.
Okay. So this is another screen you're going to see periodically, and this is called social listening. And what we've done, or the sponsors have done, MLI, is to go in social media to capture what are people saying, which gives us a good touchstone, I think, of what people are thinking and saying who are not directly seeing you as a clinician. Every time I went to the doctor, they gave me the same speech about eating right and exercising. Even though I do those things, hearing it over and over will not magically make me drop weight, and that is so true. How many times a patient said, my doctor said, eat less, move more. And I think this is a nice way to start this entire symposium this morning, is we really need to move away from the whole idea of just giving advice. You know, if you ate less and moved more, you would lose weight and your liver would be healthy and so on. And we need to move more towards giving specific strategies and tips, and along with education and accountability and guidance on what to do. I think the last thing we want to do is have patients walk away from our program saying they told me this, he or she told me the same thing that I've heard forever, and it's not helping. So you're going to see that. We put this one slide in here because if you haven't seen, this comes from the Lancet Commission on the Diagnosis and Definition of Obesity. Many of you may have heard of it. It was published in January of 2025. And I was one of the members of this International Lancet Commission, so I was a commissioner. And what we tried to do is to come up with how do we better define obesity, we'll get into that a little bit later today, and more importantly, what are the signs and symptoms of obesity if it is a disease? It's not just a gateway to other medical problems, but is actually, you could identify and diagnose it by signs and symptoms. And what this slide shows you, the figure, is as the commission came up with 18 different signs, symptoms, or biomarkers that we were able to connect the dots between obesity and dysfunctional fat and developing signs and symptoms. This is a work in progress, but the one I want to highlight, and this is why we put the slide in here, is of the 18 signs and symptoms, we identified metabolic dysfunction-associated steatotic liver disease, or MASLD, or MASH, with fibrosis. So it is a complication of obesity, although you can get it without obesity and type 2 diabetes, which we'll talk about, but it is one of the things that we as obesity business specialists, you as an endocrinologist or primary care clinician, need to be thinking more about. Dr. Nally?
I'm going to talk a little bit about the pathogenesis of MASLD with that introduction. So, MASLD used to be known as NAFLD, which was non-alcoholic fatty liver disease, and we've changed its name now about a couple of years ago. And it really is a spectrum of liver disease. So you can have simple steatosis, so just at least 5% of fat in the liver, and this is what we describe as MASLD or MASLD. And then you can have the inflammatory form of this disease where you actually have inflammation in the liver, but in addition to that, you have dysfunctional hepatocytes, so liver cells, and this is what we describe as MASH, so steatohepatitis. And then it's this feature of this disease that can really be associated with what we describe as liver scarring or liver fibrosis, and that varies in terms of how much scarring you have, and eventually that will lead to cirrhosis. Now there's a lot of risk factors, and in addition to some of the lifestyle stuff that we alluded to with that first statement, there's also some notions of having an altered microbiome, and there's a genetic predisposition as well, and we'll kind of get into this a little bit later in this talk. Things to think about are you have this influx of free fatty acids that come into the liver, and because of the systemic insulin resistance that we actually have dysfunctional mitochondria in the liver. We have systemic inflammation, and it's those processes that cause this disruption in the liver, and in turn, perpetuates this inflammation, and then also activation of these very specific cells in the liver that then lay down fibrosis or scarring. So very, very common physiological processes that we actually see in obesity, but also in type 2 diabetes.
All right, it's my turn. So one of the things that I think we're all trying to figure out how to communicate within our practices and maybe even to other colleagues is, how we can best communicate what we've learned about obesity in recent years, and how do we communicate that this is not just a problem of weighing too much. This is a complex and multi-system disease. Dr. Kushner, do you have any just sort of quick tips that you've found effective when talking with either patients or colleagues about this new approach?
Yeah, I do, Jennifer. Thanks for bringing that up. A few key things. One is patients generally don't want another disease. So to come out right away and say, obesity is a disease and you have it, is not what you want to say. I usually use the word condition. However, it is important for them to know it is not their fault. That's probably the most useful, empathetic thing you can say to individuals living with obesity. It is not your fault. It is a chronic condition with biological undertones, with forces that make it difficult to lose weight, that may make you hungrier. And for that reason, we need to think of it as a long-term chronic medical problem, often like diabetes.
Thank you very much. And actually, as an endocrinologist, I say it's not your fault about a lot of different conditions, and I need to get in the habit of saying that about weight excess as well. That's a wonderful, wonderful point.
Yeah. In a non-judgmental zone.
Absolutely.
That's the other thing you want to tell them.
So back to MASLD. So big risk factors that we think about for MASLD are obesity. We think about insulin resistance, specifically type 2 diabetes, and really just having a diagnosis of MASLD increases your risk of developing diabetes, but also has been associated to increase your risk of heart disease and chronic kidney disease as well. In the non-cirrhotic stages, specifically, it is cardiovascular disease is actually the leading cause of morbidity and mortality in that patient population. And then with more progressive fibrosis and cirrhosis, then we run into the liver-related complications. So tying in the other medical conditions to MASLD is really helpful to a patient versus just describing it as a silo disease.
So we got another polling question. What is your biggest challenge when assessing patients with obesity who may also have early or subclinical MASLD or MASH? Recognizing low-grade or nonspecific symptoms, understanding the underlying metabolic inflammatory mechanisms, knowing when to initiate diagnostic workup, connecting comorbid conditions to hepatic dysfunction, or I don't typically assess MASLD and MASH in this population.
So it sounds like maybe the low-grade or non-specific symptoms, early stage disease, recognizing that might be one of the biggest challenges.
Yep, we're going to go into that.
Yeah. So, just to comment on that slide, I mean, I think the thing that's hard with MASLD is that it's a pretty asymptomatic disease and very non-specific symptoms. And typically when patients do end up in our clinics, especially in our liver clinics, it's usually with, more progressive disease or end-stage liver disease. So it is really hard to think about a disease when your patients are not really complaining about it. So just being, really just to kind of highlight like proactive assessment and proactive screening is really important. When we think about our cirrhosis trials and when we think about endpoints, we think about two endpoints really. We think about resolution of MASH or really improvement in that inflammation that I was describing earlier with no changes in scarring. And the thought here is that MASH is what is driving that pathway to having more scarring in your liver. And then the other endpoint that we really think about is how can we decrease the scarring or the scarring that's being laid down in the liver, because it's really the scarring in the liver that's associated with endpoints such as death, cardiovascular disease, and liver-related complications. So those are the two endpoints that we typically think about and try assess in our patients. One of the things that's been very exciting in this space is that so far, most of our studies and things that we've been relying on have been liver biopsy. And we all know that liver biopsies are invasive. They're sampling a very small sample size, about 4.5 centimeters of the liver, when the liver is such a large organ. And so this FDA statement came out a couple of months ago, which is very exciting for all of us who take care of these patients, where there's a push to really use non-invasive tests. And we're going to go through some of those tests today in assessing for MASH and for fibrosis. So we put the reference here. It's a short read, but it's really informative. So you'll be seeing a lot more information on using non-invasive tests versus liver biopsy in diagnosing patients and monitoring patients.
So I'm going to take this one. This is just a summary for you, and you'll have all these slides, of the commonality among the three major organizations that have put guidelines out on treating MASLD. The first one is from the Endocrine Society, the middle one from the European societies, which work together for diabetes and liver, and towards the right is the American Diabetes Association. And they all have a commonality, which is why three of us are sitting up here today. And they really begin with the idea of obesity, or abdominal obesity specifically, along with insulin resistance or pre-diabetes and diabetes, working together in a pathogenesis of develop MASLD and MASH. And of course, the guidelines go on with much more specific recommendations, and we're going to be going over those with you later this morning. But just to say there's a commonality in how we are starting to think, a uniformity in how we're starting to think about this.
So now we're going to start off with a question. So how might characterizing obesity as both a disease and a risk factor for MASLD impact patient care? Dr. Green, what are your thoughts on this?
We've already talked this morning about maybe how we should avoid describing obesity as a disease. It's a condition. There's so much overlap, I think, between excess adiposity and MASLD and a whole host of other conditions. I don't know if it's a risk factor for MASLD so much as I think a manifestation, for example, of how that person's excess adiposity and the activity of the excess adiposity really shows up in that person as a specific problem. So I tend to approach it from a somewhat different perspective, and I think based upon our different specialties, that's probably true. So I tend to see people not because they're referred to me because of MASLD, but because they're referred to me for a different reason, perhaps diabetes management. And what we need to do is have a conversation about the spectrum of risk that they face and how excess weight may be affecting their risk of those conditions, and how also addressing the excess weight itself offers an opportunity for, I would say, we used to call it efficiency of prescribing when we're talking about medications, but efficacy of efficiency of intervention, and how weight loss, for example, as appropriate, might reduce their risk of a whole host of other conditions or mitigate their severity. So that's probably how I approach it. But I think you might be thinking of something else.
No, I've actually shifted the way I think about this, and especially with the new definition of obesity. So while being a hepatologist was very liver specific, I actually step back and think of the patient very holistically. Like, what are your metabolic diseases? Really from head to toe that are contributing to why it's so difficult to achieve your goals. So I have a very holistic approach now. So I don't just think about MASLD and MASH, but I really think about, are you at risk for sleep apnea because you have this? Because you have obesity, how is it impacting your physical activity? Are we worried about arthritis? So I'm thinking about a whole slew of other things now, and I definitely have shifted the way I take care of my patients.
I'm going to add one quick point, and then we're going to move on. And that is, I think we're getting away from the whole idea where we see a patient who has obesity, all these comorbid conditions, and on the way out, when your hand's on the doorknob, we say, oh, and by the way, if you lost some weight, it would help.
Yeah.
And I think we're now thinking of obesity as a diagnosis we need to tackle right up front, rather than something we mention on the way out of the room, which kind of brings all this together. We're going to go on to our second part now, which is the role of the liver in metabolic disease in patients with obesity. And we'll start with a polling question, so you guys are good at this now. When evaluating patients with obesity, how often do you screen for MASLD or MASH using non-invasive tests? Routinely in all patients with obesity, only in patients with additional metabolic risk, rarely unless liver enzymes are markedly elevated, or never, not part of my current practice.
It's good to see.
Are you encouraged, Dr.
I am.
Donati?
I mean, a third are thinking about and routinely screening for it. This is a big deal.
Good. Okay, one more polling question. Which statement best reflects your familiarity with current MASLD MASH screening recommendations in patients with obesity? I'm familiar with and routinely follow current guideline-based recommendations. I'm aware of the guidelines but find them difficult to implement in practice. I know screening is important, but I'm unclear on specific recommendations, or I'm familiar with current recommendations.
So there aren't a lot of people who aren't
Yeah.
familiar with the guidelines. That's nice to see, but we probably have a somewhat select group here this morning.
Right,
Yeah.
right.
Probably
Okay.
not representative of the general.
So here we have another, so screening, diagnosis, workup, and uncertainty in practice. So this is again, taken from somewhere from social media. I recently went for a health screening, was told that my liver is fatty. I'm trying to figure out what made my liver this way and what can I do to manage it. I was told to go on a low-fat, high-fiber diet and take vitamin E supplements. Gosh, what are your thoughts on this?
Well, I think we're going to spend a little bit of time talking about how we can better define the importance of understanding that the patient has a steatotic liver. So in some of the slides that I'm going to present, we'll talk about how to better understand really the severity of that condition and perhaps the implications for their longer-term health. Because this person's on vitamin E, I would assume that they don't have diabetes. So maybe there wasn't a great opportunity to discuss what other conditions may have predisposed them to develop a fatty liver. But this sounds like a person who really either didn't receive a lot of information about this condition, or it's something that I think happens all the time. There might actually have been a conversation about it, but it might have been difficult for them to hear and retain that information. So I think when we're talking about conditions like a steatotic liver disease, we probably need to be sure to revisit those conversations on a regular basis. It's very, very difficult for people to understand and retain, I think, what they've heard about it for the first time.
You know, I think, let me just add something. I think there's an important message here because MASLD and MASH are silent diseases. And I think the way you bring it up to the patient, which is what's talking about now, is so important. They're going to go, what? Yeah. And liver freaks you out. It's like something's wrong with my liver. Yeah. So really having, and you can go into this hopefully this morning, how do you talk about it in someone who is totally taken by surprise because they had no symptoms, no signs generally, and now you're telling me my liver is not functioning well or is diseased.
Yeah. I think what makes me cringe about this statement is that we still say fatty, right? Like we've changed the terminology. Fat has certain insinuations. It's never used in a positive sense. And it also, again, shifts the blame on the patient, right? Like shifts the blame on the patient. So it always makes me cringe. And this is a statement a lot of patients tell me on a regular basis, right? And I have to now unpack it, and I have to then really step back and start talking to them that this is a disease, and we're here to manage it. Like we're going to manage it together. So I think it's hard, but a lot of patients hear this.
Yeah.
It is hard, and one thing that, if you don't mind my just revisiting this, it's always a more difficult and more frightening conversation if the person is finding out about it for the first time at a point where it's very advanced. And I think that's the real concern, again, because for the most part, this is a silent condition. If we're not proactively screening and identifying that they're at risk at early stages, then it is a very alarming and much more complicated discussion when it's first diagnosed. So that's the other advantage, as with many things, to being proactive and screening people who are at increased risk, so that then the conversation can be more about what interventions are available to help mitigate my risk of really progressive and severe liver disease. So let's try to flip that conversation so it is less alarming.
Mm-hmm.
So one of the things that we're going to talk about is what additional features in patients with obesity indicate that they're at increased risk of clinically significant fibrosis. So clinically significant fibrosis is a term that you will hear a lot, which has really been attached to having a higher risk of cardiovascular mortality, also liver-related mortality, and it's really at that stage 2 fibrosis. So Dr. Kushner, do you want to take this one?
Well, it's a good time for me to bring up the word waist circumference. So one of the things that we did in the commission, which is now making its way across multiple guidelines around the world, is that we need to get away from just BMI. BMI is not a good marker for you have severe liver disease. It's really where's the fat or fat distribution located primarily, and that's in the waist circumference, the visceral fat. So all the guidelines now, at least for a BMI between like 23 to 30 at least, if not a little bit further than that, is to start doing a waist circumference, which really identifies the higher risk individual, someone who truly has excess body fat in the area of the body where it's more likely to have insulin resistance, pro-inflammatory markers, and so forth. Do a waist circumference, waist height ratio, or waist hip ratio. So that's one thing I want to add. And then along that, of course, then goes the high-risk cardiometabolic factors that's associated with that patient.
And I think this is really important, especially for, people that we think about who have lean MASLD. So patients who may not be, by BMI, overweight or obese. I think fat distribution is really important. So really getting away, like you said, from the BMI, but really trying to understand where is the fat, right? Is it all subcutaneous fat? Is it all visceral fat? I think there's some, population differences as well. So really kind of factoring that in when we're seeing these patients. But again, this is like really, let's not stigmatize, let's not associate the BMI as a reflection of how healthy or unhealthy you are. So I think that's really important.
Yeah, I mean, this takes you out of your normal flow when you see patients to do a waist circumference and a permission by the patient and the discomfort associated with it. But particularly elderly aging population, South Asian population, multiple Asian countries, BMI is low, but it may be primarily located in the midsection. So start paying attention to that, and hopefully you can develop a flow in your system to start doing that and add that to your marker regarding a high-risk patient.
I agree.
All right, so I'm going to talk about screening for MASLD and MASH, and you could give another click. I just wanted to, okay. I think the bottom of the slide, it just shows you how many groups now have sort of put their toe in this water of first recognizing that MASLD and MASH has tremendous overlap with many other conditions, cardiovascular disease, kidney disease, diabetes, of course, and obesity. But if we think in broad strokes about who should be screened for MASLD and MASH, you can see that there are at least listed on this slide 3 large buckets, including patients with type 2 diabetes, patients with obesity that has other medical complications, and we'll get to this a little bit later, but someone who has a first-degree relative with cirrhosis due to MASLD or MASH. Type 2 diabetes, if we could go back for just a second, I just want to add a little bit more color there, because that's usually the group of people whom I'm screening most regularly. It's people with type 2 diabetes who have had a diabetes diagnosis for a long time. So those who've had a diabetes diagnosis, let's say for 10 years or longer. And in particular, people who've had uncontrolled hyperglycemia for much of that time. They are at a significantly higher risk for MASLD and MASH even than the rest of the group of people with type 2 diabetes of lesser severity. And also if people with type 2 diabetes have a number of other diabetes-related complications. So those are some clues if you want to kind of start your screening approach by targeting people who seem most likely to be at risk. Those are the people that get my attention in clinic.
Can I just add to that? So one of the things that we always get told is like, but my liver tests are not high, right? So don't use your liver enzymes as an indicator for requiring screening. So we will have a lot of type 2 diabetes patients. About 40–50% of those patients will have completely normal liver enzymes. That does not mean they don't have MASLD, and that does not mean they don't have MASH. So shifting this way of thinking from you need to have elevated liver tests in order for you to be at risk for MASLD or for MASH. So basically just thinking type 2 diabetes, I should be thinking about MASLD and MASH just like I do about annual eye exams, and other things.
Exactly, and I think even if you're in that sort of upper portion of the normal range, that's probably not normal. But as you've mentioned, by the time the LFTs are abnormal, then that person actually may have quite a bit of inflammatory activity and maybe even established fibrosis. So we don't want to wait until there are gross abnormalities in the GI panel to start thinking about screening. Now remember, not every person, for example, with diabetes and steatotic liver has MASLD, and we need to make sure that we are at least considering whether or not there are other etiologies of their liver disease or perhaps additional etiologies of their liver disease. So this is a suggested algorithm that helps us kind of categorize and decide whether or not this person has MASLD, or maybe they have something else. If they have, one of the first steps in this algorithm is deciding or determining whether or not the person has any of the cardiometabolic criteria, which are not listed here, but just so you know, essentially the cardiometabolic criteria are the components of the metabolic syndrome. So for example, do they have excess, is their BMI elevated? Do they have dysglycemia? Do they have hypertension? Do they have high triglycerides or a low HDL? And they really only need to have one of those. If they have multiple, then you're really good to go. But if they don't have any of those components of the metabolic syndrome otherwise, then you go down that right-hand side where the answer is no, and think about whether or not there might be other causes of steatosis. And some of the other conditions that could be considered for a person like that would be alcohol-related liver disease, drug-induced liver injury, for example, or sometimes people have liver disease of unclear etiology. However, most of the patients that we see are going to have at least one of these cardiometabolic risk factors, so we'll go down the left-hand side of the pathway, but still there we need to think about whether or not there may be any causes. And there are some new categories of MASLD where, for example, people will have both metabolic liver disease and excess alcohol intake or alcohol exposure. So there's a new definition of MET-ALD that represents and is the preferred term for liver disease that is related both to the dysmetabolic state and to excess alcohol exposure. But if they don't have that, then you can be fairly confident that your diagnosis of MASLD is correct. But we don't stop there. And this is something we spend a lot of time talking with our trainees about in clinic. So, once you've decided that their hepatic steatosis is likely due to MASLD, then you need to really better quantify who is at risk for advanced fibrosis. We don't just say, oh, they've got MASLD, and then start prescribing drugs or making recommendations. We need to understand and identify people who are at the highest risk for example, ultimately developing advanced liver disease and/or cirrhosis. And in my hospital, it's very easy. The VA, if you order a GI panel and the other data are available to calculate the FIB4, it does it right there for you. It's reported at the bottom of the LFTs. So all that you need to calculate the FIB4, which is a very, very important tool in assessing risk, are age, AST, ALT, and the platelet count. And you know, endocrinologists sort of have gotten away from ordering CBCs routinely, so if you don't have a platelet count available, you may need to tack that on really to calculate the FIB-4. But the nice thing about the FIB-4 is, in a lot of my patients, I'm going to get a FIB-4 calculation that's less than 1.3. And that's nice to see. That means that that person at that point in time is unlikely to have advanced hepatic fibrosis. And so there's no additional workup required for that person, but you do need to periodically reassess that because people's risk will change over time. So maybe recalculate that every year or two to make sure that you're understanding whether or not their trajectory of risk is changing. If the FIB-4 is greater than 2.67, I'll show you some additional slides. That's a person who is considered to be likely to have advanced hepatic fibrosis, so stage F3 or F4 fibrosis, and that person is definitely going to need some additional evaluation. And then there is a bit of a gray area, so if the FIB-4 score is between 1.3 and less than 2.67, it's indeterminate, and we'll talk again about how to further evaluate those individuals. Remember, too, that the FIB-4 is designed to be most accurate in patients between 35 and 65 years old, so if you're calculating a FIB-4, and I always have to look this up, in somebody who's older than age 65, you get a little bit more leeway. Your score is allowed to be a little bit higher before you become concerned. I don't think we have a lot of information about that, but just be aware that for the much younger or much older person, these cutoffs may not be precisely appropriate.
So once you get a FIB-4, that helps you initially risk stratify someone for whether they're at risk for having advanced fibrosis or not. So in those who have the intermediate range, so the people who have a score between 1.3 and less than 2.67, it's important that we do some form of secondary assessment. And we're going to go through two of the ones that are recommended by a lot of our guidelines. So the first one is something that's commonly referred to as FibroScan. So it's vibration control transient elastography. Basically what it does is it's very similar to an ultrasound-based technology, but it sends a vibration wave across the liver, and the speed of that vibration wave basically correlates with how stiff your liver is. So the faster the speed, the more stiff your liver is, the more likely to have more scarring. You don't need to memorize these cutoffs. When you do order a FibroScan, you will hopefully get a report that will tell you where that patient sits in terms of risk of having fibrosis. The nice thing is you can also get a score, a quantification, a semi-quantitative value for how much fat is in the liver as well, and that's determined by the CAP. The other secondary assessment that has been recommended by society guidelines is something called the ELF test, so the Enhanced Liver Fibrosis Test, and this is a combination of 3 direct markers of fibrosis as listed over here: hyaluronic acid, procollagen, 3-amino terminal peptide, and metalloproteinase as well. And this again can also be used to prognosticate and try to find if someone is at risk of having advanced fibrosis, but also the likelihood of someone running into trouble. Just so everyone knows, this has been approved for a few years. It's not really used very much, and it's available at LabCorp and Quest. So if you don't have it in your healthcare systems or in your practices, you can always give patients a requisition to get this done at a lab.
And then just to provide a little bit more insight into what we do with the FIB-4 scores, as I had mentioned, if the FIB-4 is less than 1.3, again, then just periodic monitoring is recommended. If the FIB-4 is 2.67 or higher, you can always send right to hepatology. They'll do some more non-invasive testing to better understand the person's degree of hepatic fibrosis and risk for cirrhosis, which may or may not include a liver biopsy or other additional testing. But again, this indeterminate range is where you're going to do the elastography or the ELF testing. I will tell you, sometimes the ELF testing is a nice option if there's a bottleneck to get the elastography performed. Sometimes you may be in a healthcare system where there is limited access, or there's one person who has a machine who can get it done, and it's not easy to do that in a timely fashion. So the ELF test is a very nice alternative and is considered a reliable means of assessing hepatic fibrosis. I have a question for Dr. Donani, and we always ask our patients about family history, and as I'd mentioned, we were talking about some of the higher risk buckets of individuals, but can you enlighten us a little bit about how family history factors into risk for MASLD and MASH and complications thereof?
Yeah, of course. So family history is really important because we have genetic influences, but also environmental influences that predispose you to having MASLD. But we do have studies that have shown that if you have a first-degree relative who has cirrhosis as a result of MASH, you are, irrespective of environmental risk factors, at about 12-fold increased risk of having MASLD. And this is probably driven by a lot of our genetic risk factors or genetic polymorphisms that we've already identified. The PNPLA3 mutation is involved in, like, for instance, triglyceride form with triglycerides, is heightened in patients of Hispanic origin. The least genetic risk we found so far is in the Black population, so asking that family history is really important. A statement that I never understood when I was younger is, your children are a reflection of you. And now having children, I think about it, their environmental influences are really dictated by what we expose them to. And so the environment is also very, very important to understand. Like, how do you eat as a family? What do you do about physical activity as a family? So I really, really dive into some of those features as well. But the family history is big. And really just asking that question, because it should really, really make you think about being proactive about intervention.
Yeah, and I think I see a lot of the family history and medical notes just being carried forward decade after decade, and it's probably a good idea for us to revisit that.
I want to move on to a little bit more about clinical care, and we're going to get into the next section in a moment. But it's to remind us that this is a team sport. There isn't one individual who's going to manage obesity and MASLD and sleep apnea and congestive heart failure with preserved ejection fraction and sleep apnea and diabetes. It's a very talented individual who could do all that, but really it's really a multidisciplinary team. In the center of it is the patient. In this case, it's the patient with MASLD, but we have primary care doing the evaluation. Endocrinology may be doing it as well. They're going to be evaluating the patient for lipid disorder, managing diabetes. Going clockwise, we have nutrition, lifestyle intervention, which is foundational to the management of patients with obesity or MASLD, but there are other interventions, which we'll get to in a moment. And then as we continue around the clock, we get to the bottom right, gastroenterology and hepatology. So the key is, how do we work together and not work in silos, but actually work together to manage this patient is the key thing. This is kind of a summary slide regarding the management algorithm, which we've already heard from Dr. Green. Towards the right, we're going to look at high-risk patients with prediabetes and diabetes, those with high-risk obesity, visceral fat, increased waist circumference, with other cardiovascular risk factors, or someone who comes in with hepatic steatosis picked up on a previous CAT scan or MRI that they didn't know about that may need to be looked at further. Initial evaluation is going to be screening for diabetes for sure. Lipid panel, and you could use statins in this. And the key thing is we want to prevent cardiovascular disease outcomes, which is the number one reason individuals with MASH suffer outcomes from is cardiovascular disease, and prevention of cirrhosis. And of course, we talked about the fibrosis risk stratification. So it's another way of summarizing that algorithm of what we're going to be doing. Here's another panel discussion. What role do biomarkers and NITs play in risk assessment in patients with obesity? I'll go ahead and answer that myself so we can move on. We have already talked about some of the FIB4 would be a non-invasive risk assessment. Me as an obesity medicine specialist, this is a newcomer to me. Fatty liver disease has been a silent killer. I've always looked for increased LFTs, and now, of course, we've learned that is not a good way to look for it, that we need to look further beyond just increased LFTs, which are not very sensitive to picking it up at all. So I want to get into emerging options for treatment of MASLD MASH in patients with obesity. We'll start off with one polling question. When considering pharmacologic therapy for patients with obesity or MASLD MASH, what is your most frequent source of uncertainty? Understanding mechanism of action and target pathways, comparing efficacy among available agents, determining when to initiate pharmacotherapy, managing overlapping comorbidities, or monitoring treatment response and side effects. It's like a horse race, you know?
No.
Determining when to initiate pharmacotherapy and monitoring treatment
Yeah.
response and effects seems to be the main things there. Okay. Thank you.
Okay, so I don't know if we're going to have enough time to talk about monitoring treatment response adequately. That was a whole other program. But, you know, this is a person who had commented that they've been trying lifestyle modification for years. They've lost some weight, but the liver fat isn't going down. And their hepatologist suggested that they could consider one of the new obesity drugs. But it sounds like maybe that conversation wasn't long enough or detailed enough because the person isn't sure if it's worth it or if lifestyle alone should continue. Now, this is a big and complicated discussion, and I don't think that we know enough about this particular individual to make that determination, but that's where I think really better quantifying the extent and severity of their liver disease, taking the whole person into consideration, and whether or not they have other conditions or complications that might benefit from pharmacotherapy for obesity itself. Might be of benefit. And then we're going to go also through some of the guidelines that can help us, particularly for people with diabetes and MASH, that can help us to make recommendations regarding use of specific pharmacotherapies. And how do I counsel patients on the role of targeted therapies? Again, I believe I touched on this a bit earlier. I think that excess weight for many individuals is one of the key drivers, and we talk about this all the time, and it's in the ADA guidelines now. This is one of the key drivers of both the development and progression of type 2 diabetes. So it is discussion about weight as appropriate, and weight management is really foundational to management of diabetes, to MASH for many individuals, as well as a whole host of other medical complications of excess weight. And so I like to talk about it as more an opportunity than just adding one more problem to the list of things that they have to worry about.
So how do we actually begin thinking about treatment? I've mentioned before that lifestyle management really is foundational. Even as obesity medicine specialists, living in this transformative time of having the explosion of highly effective obesity medications available. Foundationally, it really is still how does someone take care of themselves, and then you add on to it. And there's three different areas that you need to be think about when you're seeing patients living with obesity who present with MASLD or MASH. One is regarding the obesity is to reduce the caloric intake. That is how people lose weight. GLP-1 receptor agonists allow people to reduce their appetite, so they actually reduce calories, but reducing calories is so important to losing weight. Uniquely with MASLD, we talk about fructose because that has been found. Biggest sources of fructose that we're concerned about in our environment are sugar-sweetened beverages and fruit juices. Table sugar is also glucose and fructose. You may have forgot about that, so be aware of fructose. And of course, alcohol. The weight loss we talked about, we're going to talk about just in a moment how much weight loss and what kind of data do we have regarding what is the target of treatment regarding how much weight loss we are shooting for. In generally 3 to 5% improved steatosis, as well as a whole lot of other problems like prediabetes or hypertriglyceridemia or elevated blood pressure, but 7 to 10% you need or more for MASH or fibrosis resolution. And then also exercise. We have data that exercise alone will reduce steatosis in the liver, but not necessarily effective for MASH and fibrosis. And you want to give them targets. You don't want to say just move more. You want to give them targets, like how many steps a day you should be aiming for, 8,000, for example, or how many minutes per week you should be aiming for in order to take some weight off. This is one of the studies available in literature that a lot of the guidelines have quoted. This is a study of 1 year duration in which individuals, about 260, were put on a lifestyle program with liver biopsies before and after, looking for steatosis, MASH resolution, fibrosis resolution. And what you see very nicely is the categorical weight loss as it's associated with resolution of these three different categories. And in this study, 100% of patients who achieved a 10% or more mean weight loss saw improvement in steatosis. One caveat I want to add, though, is that of the 260 individuals, 70% of them lost less than 5% body weight. So the rest of the 30% were equally divided into the other categories. So the take-home message is that in order to reach the target you're looking for, it is very difficult to do that with lifestyle alone. Although it's foundational, it's hard to do it by itself. So adding a biological agent like a medication is often needed. And I also want to mention bariatric surgery. It's the only slide we have on bariatric surgery. This is called the BRAVE study, which was an open-label, randomized controlled trial where individuals were randomized to lifestyle management for a year or randomized to Roux-en-Y or sleeve gastrectomy. And we see the outcomes being NASH resolution without worsening fibrosis or improvement of at least one stage of liver fibrosis without worsening NASH. And what you see is that both of the bariatric surgical interventions were, I think, certainly more successful than lifestyle in achieving both of these outcomes, 60% and 40% respectively. One other caveat I want to mention is that the Roux-en-Y caused a mean 32% weight loss, where the sleeve gastrectomy caused a mean weight loss of 23% weight loss. It wasn't quite the same, but yet the effect on the liver was the same, which suggests to me that it's not just weight loss in this case, it's other biologic mechanisms of bariatric surgery, not just weight loss.
And if I could just jump in there, what I tend to see often is that the metabolic surgery is left as a last resort, right? After you've tried everything else and it's not successful. And I think we're going to talk about pharmacotherapy. I think we need to move the option of metabolic surgery much earlier in the conversation, where first of all, the person's probably in better health and better able to tolerate the surgery itself, but also it's very clear that a whole host of other outcomes will be improved, and earlier is often far, far better in that respect as well.
Yep. So and we're going to talk more about this in just a moment. We have two medications that have conditional FDA approval for MASH with fibrosis F2 to F3. Resmetirom, which was in March of 2024, and more recently semaglutide in August 2025. Conditional means that they still have to prove the clinical significance of this. This is an intermediate marker, that they have to prove the clinical significance by reducing the occurrence of cirrhosis or other liver-related disorders. That would give them full approval. Right now, they're conditional approval by the FDA. And lastly, before I turn over to my colleagues, my other panel members, is that the unique thing about GLP-1 receptor agonist and the GIP GLP-1 dual receptor agonist is that they have pleiotropic actions. They not only cause weight loss by change in appetite, but they have effects throughout the body. In the pancreas, we know because of diabetes, as well as now in the liver. And that is why they have been shown beneficial in so many other organ benefits other than just weight loss. So panel discussion, what role do you see GLP-1s playing across the low and versus intermediate high-risk settings? I'm going to summarize it because the shortest of time, they play a big role. And we're going to move on to this. This is a very nice visual from the ADA guidelines. I like it because it talks on the left towards how to take care of the patient, healthy lifestyle, weight loss is important for obesity, optimal diabetes management, and then it takes the different fibrosis scores and links them specifically to how do you treat the obesity through pharmacotherapy, diabetes through pharmacotherapy, and MASH through pharmacotherapy. And you're going to have this slide that you can go ahead and look at on your own. It'll take a long time to walk through, but we do need to have a good understanding of the underlying factors, diabetes, as well as obesity, and what the level of the liver injury is or the fibrosis, which will then dictate what medications we can use or cannot use.
Okay. I'm going to talk a little bit about the 2 agents that have been conditionally approved for a MASH. So both these agents, both resmetirom and semaglutide, have been approved for patients with significant fibrosis. So that means patients with stage 2 to 3 fibrosis. In combination with lifestyle changes, these medications have not been approved for patients with compensated cirrhosis or decompensated cirrhosis. So these are the results from the phase 3 randomized control trial of resmetirom in MASH who had liver fibrosis. And you can see here from the graph on the right side, NASH resolution with no worsening of fibrosis was achieved in patients who were randomized to resmetirom 80 milligrams daily and resmetirom 100 milligrams daily compared to placebo. And I always talk about a delta change of about 14-15% compared to placebo. The other endpoint was fibrosis improvement in 1 stage with no worsening of the steatohepatitis features. So again, at both doses of resmetirom of 80 milligrams and 100 milligrams compared to placebo, we saw an improvement in fibrosis with no worsening of MASH. So this was the analysis that led to the conditional approval, and the readout for the complete study is not going to happen for a couple of years. These are the results from the phase 3 trial. So it was part 1 and part 2. So this was a part 1 planned analysis of semaglutide in patients with MASH. So again, for patients with significant fibrosis in combination with lifestyle, again, you can see it compared to placebo. Semaglutide 2.4 milligrams weekly demonstrated an improvement in steatohepatitis compared to the placebo arm with no worsening of fibrosis. So again, here the delta is about 30% for MASH resolution. And then for fibrosis improvement with no worsening of steatohepatitis, 36-37% compared to 22% for placebo. So again, based on these results, led to conditional approval.
And this is looking at the data we have from tirzepatide. It was a sub-study of the SURPASS-3 trial, which was 3 doses of tirzepatide versus insulin degludec, and you can see it all here. And the primary outcome of this sub-study was the change in liver fat content, or LFC. That's what the graph is showing. So you have a C to 3 different doses of tirzepatide versus insulin. This was a 52-week trial. The numbers just above the bars is the baseline liver fat content percentages. And what you could see is that all 3 doses of tirzepatide were statistically, probably clinically significant beyond the use of insulin, demonstrating, at least as of this point, tirzepatide is reducing steatosis.
And to carry on in a similar vein, this slide summarizes the phase 2 findings of a tirzepatide trial in patients with MASH and moderate or severe fibrosis. And this is a little bit difficult to read, but what you can see looking at similar endpoints as shown on the previous slides, that the 3 different doses of tirzepatide tested significantly improved these important liver health outcomes compared to placebo in this patient population. And we can't forget, I just want to summarize quickly that pioglitazone has long been a drug that has been used for the treatment of MASH in people with prediabetes or type 2 diabetes. It does not have an indication for the same, but you can see on this slide that pioglitazone treatment in this patient population has been associated with improvements in the grade or stage of MASH in patients with prediabetes or type 2 diabetes. And I think if we click forward, there's one more. Yes, and that pioglitazone, again, compared to placebo in patients with MASH and prediabetes or type 2 diabetes, was found to result in reduction in and/or resolution of NASH to an extent greater than placebo, again, in this particular patient population. And it is a medication that we've been used. Now, one thing I would point out is, if I remember correctly, the dose of pioglitazone used in this trial was 45 milligrams, which we tend to not use as often clinically. But this is another option for our patients, and a less expensive one, albeit without an indication. One of the ways that we can at least theoretically mitigate the risk of weight gain with use of pioglitazone for these purposes or for diabetes management, and potentially also mitigate the volume expansion associated with use of pioglitazone would be to use combinations of the drugs, particularly with use of an SGLT2 inhibitor, or if you're looking specifically to mitigate the risk of weight gain, to give pioglitazone along with an incretin-based therapy that can provide a weight loss benefit. So many of these patients would be treated with more than one agent. So if you're interested in incorporating pioglitazone for the purposes of reducing risk associated with MASH in people with hyperglycemia, think about use of a combination.
There's lots of emerging therapeutics in this MASLD space, and this is just a summary of some of the agents that are being investigated. I think if we, so we're going to talk a little bit about survodutide. It's a very exciting molecule because it's a combination of a GLP-1 with a glucagon receptor agonist. Then we have a combination of our pan-PPAR, so different from pioglitazone, but really targets all three receptors. So lanifibranor currently is in phase 3, and we'll have a readout in the next couple of years. And then other molecules as well, currently going, just read out for the phase 2 results, really thinking about interruption of triglyceride metabolism. So the glucagon GLP-1 combo is an exciting space for MASH, is because in addition to all the effects of a GLP-1 receptor, the glucagon component works very specifically directly on the liver and does two very specific things, which is energy expenditure and breakdown of triglycerides, and so basically lipolysis. And it's really the combination that has been thought to help with hepatic steatosis, inflammation, and also deactivation of our stellate cells, which are those specific cells that lay down fibrosis. And this slide here summarizes the phase 2 results, which has led to the current phase 3 program for survodutide. So here what you have is patients were randomized to different doses of survodutide, 2.4 milligrams, 4.8 milligrams, and 6 milligrams compared to placebo. And again, the two outcomes, the primary endpoint was improvement in MASH with no worsening of liver fibrosis. And you can see in a dose-independent effect of survodutide to improve MASH with no worsening of fibrosis compared to placebo. Similarly, in the secondary endpoint, looking at improvement in one stage of fibrosis with no worsening of MASH, this was also demonstrated with all 3 doses of survodutide compared to placebo. And so this has led to the current phase 3 program, where it's being investigated in patients with non-cirrhotic MASH as well as cirrhotic MASH.
So this is our very last slide, and we're actually out of time. So I'm just going to pose this to everyone, rather, with maybe quick comments from you guys, is how can primary care and specialty clinicians work together to improve awareness and implementation? As I said before, we need to break down our silos. We really do. I think this is the biggest challenge we face. We're all pretty smart. We're going to learn this information, but how do we implement this in the healthcare system? Working with multiple professionals is probably the key challenge.
Well, one of the things that I would say is, the multidisciplinary clinic model is wonderful. If you have that available to you in your area, that's not going to be feasible, and we're also not going to be able to refer every patient with MASLD or MASH to a gastroenterologist. So one of the ways that I think we can constructively improve outcomes in this patient population is for general medical physicians or endocrinologists to become more aware and really be empowered to take those initial steps in both screening for disease and then better understanding and identifying those who are at highest risk for adverse outcomes. And that can allow us to more effectively triage our patients and actually use the other subspecialists' time most wisely.
I agree, for the purposes of time.
Thank you. Listen, thank you all for attending. As mentioned, claim your credit for the symposium. Please scan the QR code and visit mli.link/. So use the code is the key thing here. And really, thank you very much for coming. Enjoy the rest of the meeting.